So for all practical purposes, today what we'll be discussing only would be only about cancers arising from the follicular cell of the thyroid. And when it arises, it can arise either as a differentiated cancer or as an anaplastic cancer. So the
So the
anaplastic
anaplastic
cancer
cancer
is
is
one of
one of
the
the
deadliest
deadliest
cancer
cancer
that
that
humankind knows. I mean, it is even worse than pancreatic cancer or any other cancer you can think of that has the highest mortality. The anaplastic cancer, you can see it grow in front of your eyes on a day to day basis, and you can see them drop dead in a matter of days. And, God forbid if we went and operated on this patient, you are sure that we're not going to be able to discharge them alive. So, in most instances, very, very rare that they will be such a small cancer that we can get away with it. So, anaplastic cancer is one of the deadliest cancer. But by far, all the rest is a differentiated cancer, and the differentiated cancer would be either called papillary or it could be called follicular. They could be called Hertel cell as well. So Hertel cell is also of follicular origin. There are some people who try to confuse that whether if Hertel cell was, a cell carcinoma it was not arising from the follicular cell or from a different cell. So Hertel cell is also arising from the follicular cell. And so these cancers are all clumped together as the differentiated thyroid cancer. All right. So when we have the differentiated thyroid cancer, then we also know that we have to have a fair sense of proportions. Most of the cancers would be papillary, and a small subset is going to be follicular. And this again, if you looked at it historically, earlier 20 years ago, people used to call equal numbers as follicular and papillary. But because the definitions kept varying in the pathology, more patients were included into the papillary category and less patients were now into the follicular variety. And this is the latest proportion that you can have. You will see that in this slide, 84% of them are all categorized as papillary cancer, whereas follicular carcinoma, that is a true follicular carcinoma, is reduced to only 2%. And then the poorly differentiated, the anaplastic, all of this are again arising from the follicular origin, but it is given separate. Again, one third of the cases are classical variant papillary cancer. Now, all the other things, the tall cell variant, which is considered as a very poor outcome of the papillary cancer, or the so-called follicular variant of thyroid cancer, or the follicular variant of an encapsulated thyroid cancer, all this gets included. And these were all earlier, 20, 30 years ago, were considered as follicular, but now they have been moved into the papillary category. So now we have majority of the thyroid cancers, the differentiated thyroid cancers included in the papillary carcinoma of thyroid. Any questions? Can we move? Yeah?
Yes, sir.
Yes,
All
sir.
right. So, if you guys are interested in knowing a little bit more into the molecular details about why things are the way they are, you will understand that this is whole thing is determined by three group of genes. You can call one as BRAF, the other is the RTK or the tyrosine kinase genes, and the other one as the RAS genes. So the tyrosine kinase genes are what will determine the classical papillary cancer thyroid. So if you look at the papillary cancer, what are the criteria to diagnose a papillary thyroid cancer? You should have papillae. Papillae means it will have a papillary structure with a central fibrovascular core. You should have some amount of bodies. You should have within the
Orphan
cellular
Annie.
orphanani nuclei or ground glass appearance of the nuclei. All this, most of the papillary cancers are actually diagnosed by nuclear details. Okay, so the nuclear details, whether it is orphanani or ground glass appearance or other kind of changes, they are the ones which will determine the diagnosis of a papillary cancer. When the RAF or BRAF genetic change happens, this papillary cancer becomes the poor prognostic variety called the tall cell variant. Okay, And if there was more of RAS genes which are affected, these cancers become kind of follicular cancer. So if you looked in the bottom, the so-called differentiation changes from the this extreme to the other extreme, which is follicular cancer being the extremely well differentiated, which is determined by the RAS set of genes. The classical papillary is middle ground, in differentiation, which is determined by the tyrosine kinase genes, and the worst variety, the poorly differentiated ones, are determined by the BRAF. Okay, the why we need to know is these guys are now utilized for some kind of a precision diagnosis as well as treatment, targeted treatment. So that is why we need to have some sense of the background of this molecular details. And here again, um, the earlier I showed you that in a follicular cell, it can either go into the differentiated category or into the anaplastic category. But it is not so dichotomous. You could start with a papillary cancer, and over a period of time, if you did not treat them, like let's say we ignored them for 5 years, 10 years or so, they have the potential to transform into poorly differentiated cancer or anaplastic cancer of the thyroid. And these are the genetic changes. For the anaplastic to take place, it is determined by the changes in P53 gene, and if it is the poorly differentiated, it is determined by the RAF and the RAS genes. Okay, so basically, papillary cancer, when it as it starts with, will not continue to stay as a papillary cancer over a period of time in its natural history. It has the potential to become poorly differentiated or the anaplastic cancer. So why we need to know this is we have certain tumor markers. So you see, if it was a papillary cancer, you have the excellent tumor marker as thyroglobulin. Same is the case with follicular. You have a good marker, the same is the thyroglobulin. But if you looked at anaplastic, you will not have a tumor marker. So there will not be any kind of differentiation whatsoever, and it will not produce any kind of chemical substance in the blood so as to detect or identify them as anaplastic cancer. So anaplastic cancer would be more by exclusion and by high index of suspicion. Okay. Of course, medullary has tumor marker of calcitonin and CEA, which we are not going to be discussing today. All right. So when you have papillary cancer of the thyroid or differentiated cancer of the thyroid, the next step is decide, how do we confirm this test, I mean, diagnosis, and how we stage the disease. And both of which have very standard. The ultrasound of the neck is mandatory, and cytology of the nodule is mandatory. Now, besides these two, what are the other investigations we need to do will be determined by the extent of clinical extent of disease. In the sense, let us say we have thyroid whose lower limit we are unable to palpate. That means the thyroid disease is going behind the sternum and into the mediastinum. Suppose if that be the case, an ultrasound will not be sufficient because the bone will be a huge obstacle for the ultrasound to see beneath. So therefore, in that instance, you are required to have an MRI of the neck. Why MRI of the neck instead of a CT scan? The reason being, if you use a CT scan, the plain CT scan will not give you as many details, and we don't want to use a contrast in the CT scan because that is going to take away your urgency to do radioactive iodine
Radio.
treatment subsequently. Correct? Yeah, you're absolutely right. So that's the reason why we would use the MRI in preference to the CT scan. But is there a specific indication where we'll actually ask for a CT scan, although we know it is going to delay the radioactive iodine? Do you guys, anybody know an instance when we have to definitely get a CT scan with contrast? Anyone can tell me?
Secondary snake.
Secondary snake is usually in the lymph nodes. The lymph nodes are easily picked by the ultrasound or the um, MRI. So why do we need a CT scan?
Did George turn on extension?
Critical invasion,
Ecosystem extension we can pick up with a MRI. Why do we need a CT scan?
critical invasion,
Excellent. So the advantage of having the CT is to only determine bone invasion or cartilage invasion. That is the secret of using the CT scan. So in any case where you think there is involvement of the bone or cartilage, you will definitely use the CT scan in preference to the MRI. So if you want to assess whether there is thyroid, I mean tracheal cartilage involvement, or if there is thyroid cartilage involvement, or for that matter, you can also have tracheal extension of the tumor. Sometimes they will be infiltrating into the prevertebral fascia, into the vertebra. They can be encompassing the carotid vessels. All these are good indications to do a CT scan because you're not worried about the iodine part. You're worried about exactly knowing the extent of the disease so that it is important and appropriate for you to plan whether it is possible to resect the disease completely without leaving behind any residual disease. So that is when we talked about what is called as a locally advanced thyroid cancer, or in, as one of you said, in a metastatic setting. But the other extreme is where it is very, very localized. You're seeing only 1 centimeter, 1.5 centimeter, 2 centimeter tumor, very much is intrathyroidal. It is moving with deglutition, and you're able to move the thyroid gland in both directions, vertically and horizontally. So, if that be the case, then there is no reason why we should go and do all the other investigations. In that instance, you are only having to decide, is it possible to manage with a conservative surgery or should we do a radical surgery? That is the question that you need to answer when it is very, very small, early stage and confined to one lobe. So, if that be the case, then you will ask certain different questions. The questions then you will ask is, uh, for an early stage disease, is this patient young, is a age between 15 years and 45 years, okay? Whether if this patient has had a previous radiation to the neck for any other reasons, okay? Or is there any lymph nodal metastasis or extrathyroidal disease that you're suspecting? And you will also check whether if it is more than 4 centimeters in size or not. And in the cytology, you will carefully look whether there is any poor prognostic variant. The poor prognostic variant, like we previously saw, is the tall cell columnar variant, or it could be the Hertel cell element, or any other such a kind of cancer that would predict poor prognosis. If none of this is there, the age is and not older age group, there is no previous radiation, there is no other signs of metastasis or extrathyroidal disease, and the histology is also a favorable histology, then there is a strong argument to look at only hemithyroidectomy as an option. Sometimes doing a total thyroidectomy can be an over treatment, or in other words, you could be landing up with a higher rate of complications. So, therefore, hemithyroidectomy alone would suffice, but you should use very, very strict criteria that they must be within this safe age group, which is 15 to 45. They must not have had any previous radiation. There is no multicentric disease. There is no extrathyroidal disease, no nodal or distant metastasis, and there is no aggressive histology. If after doing a hemithyroidectomy, if you find any one of this, that inadvertently you find out it's poor histology, you at that time find there was a lymph node which has already been involved, you will find that there is multicentric disease, you find that there is extension into the scap muscles quite extensively, then you have no other job but to go back and complete the thyroidectomy. You cannot leave it with a hemithyroidectomy alone. So the hemithyroidectomy is exclusively only for people for whom there is an extraordinary safety margin. For all other people, we'll have to do a total thyroidectomy. Do you guys follow? So you do a total thyroidectomy in such a way that you don't leave behind any kind of gross disease at all. Okay, so you should ensure that there is proper microscopic margins, and then we can eradicate the disease completely just by surgery alone. So at this juncture, what I would also do is I'll guys probably show you this video on the thyroidectomy. Are you ready? So let's go a little bit into detail about the thyroidectomy. See here we have a 20-year-old guy who had thyroid cancer, and that's the anatomy just for you to understand. So this thyroid extension
Video is not playing, sir.
video is not playing. How is
Yes, sir.
that? Okay, let me just. I should do some sharing business, isn't it?
Yes, yes, sir.
Okay, I'll do that. Stop. Oh, I should go to stop share and then start the video, isn't it?
Yes, sir.
Okay, let me.
Start the video and then share, sir.
Okay, start the video and then share. 1 second. Share screen. Share. Okay, now it's visible.
Yes, sir. Yes.
All right. So I think we are the steps of the surgery we can stop in between. So you can see the incision. Did you guys see the positioning of the patient? It was what is the structure now? It's being cut.
Platysmas.
Platysma. So is the platysma subcutaneous or is it beneath the deep fascia?
Subcutaneous.
Okay, so that is what we are doing now. So that is so what we are doing now is we are raising the flap in the subplatysmal plane. Can you see there's a lot of loose areolar tissue? That is the subcutaneous plane in which you're going to be dissecting the flap. And what is the extent to which you're going to be elevating this flap?
Thyroid cartilage.
Sorry?
Thyroid cartilage.
We should go right up to the hyoid.
Thyroid.
Hyoid. So you go past the, see this is, you can see the thyroid cartilage. This is the Adam's apple. Okay, you should go right up there for the hyoid bone. And in here you go right up to the
Suprasternal
Jugular
notch.
notch.
absolutely, yeah. So this muscle is what? The forceps
Sternohyoid.
sternocleidomastoid muscle, this one.
Sterno.
This is your strap muscles. What we are doing now is to incise the strap muscle in the midline. Can you see that? So the sternothyroid and the sternohyoid muscle and the thyroid hyoid muscle, finally, we are going to be incising. Can you see that?
Yes, sir.
As you kind of incise these muscles, then you can retract these.
Pretracheal fascia.
Yeah, not pretracheal fascia. We are going to be going towards the thyroid fascia. We are going to retract this muscle. Okay, there are two ways. You know, if you have any clinical suspicion that the cancer is involving the strap muscles, then you should not do this. You should resect the strap muscles along with the cancer because that means you leave behind microscopic disease. See, this muscle is the omohyoid, the superior belly of omohyoid, which is coming from the lateral. So that is what you're finally picking up and dissecting. All of these go and attach to the hyoid bone finally. Okay. So release that muscle and then retract it. And then with some blunt dissection, you're trying to get to the superior pole of the thyroid gland. So that's the first step we do. So you make a plane between the thyroid and the fascia there, and then you look at the pedicle, superior pedicle. When you dissect the superior pedicle, you carefully watch for the nerve. Which nerve will you watch for?
External laryngeal.
It's the branch
Superior
of the external laryngeal,
Superior.
superior laryngeal nerve. Okay, what does the superior laryngeal nerve do?
Supplies cricothyroid.
Supplies cricothyroid. What else does it do?
Sensory supply above the vocal cord. Above the glottis.
Sensation to the supraglottis. Okay, so if you cut this nerve, then you'll have anesthesia of the supraglottis, and that can lead to aspiration. Okay, so what will be the voice change if you cut the superior laryngeal nerve?
Loss of high pitch of voice.
Yeah, it's called voice fatigue. If you have to keep on talking like that, lecture like this over a period of time, you will. Can you see the superior laryngeal nerve just demonstrated? Should I go back?
Yes, sir.
You guys saw, or should I go back?
Please go back, sir.
Okay. So now after dividing and ligating, I will freeze it when I'm showing that superior laryngeal nerve. So this is the technique to do this is you have to go as close to the gland, but at the same time you should not leave behind the 1 minute. I'm going to show you. That is enough. Can you see that white guy, white line? 1 minute. You label it. Yeah. Did you see that? This guy
Yes, sir.
is
Yes, sir.
labeled. So that is the superior laryngeal nerve. So this fortunately was a little higher up. Otherwise, if it is lower down, we'll have to dissect this nerve, separate it, and then ligate the superior pedicle. All right. So we're going to proceed. Now, after you did that, you would now go what is known as extrafacial approach. Can you see that? The extrafacial approach is very important here because this will be the superior parathyroid gland. Can you see that? So this fatty tissue will contain the superior parathyroid in it. Once you kind of preserve the superior parathyroid gland, then you can start dissecting the pedicle even further. Parathyroid gland, superior parathyroid gland. Anyone? What is the blood supply for the superior parathyroid gland? Now we identified and preserved. Yes, preserving the gland is of no consequence. You need to preserve it with its blood supply. So therefore, you should know where the blood supply is coming from. Where is it?
Inferior thyroid artery.
Exactly. So the inferior thyroid artery is the one which is going to supply both the parathyroids. So when you go further, you'll have to identify the inferior thyroid vessel here and then dissect it towards its terminal branches and then divide it and not ligate the inferior thyroid artery at its origin. Is that clear? If you did that, you're going to devascularize all the parathyroid glands. So here we are actually trying to trace the another important nerve. What is the important nerve here?
Recurrent laryngeal.
So you can see we are trying to separate and retract the trachea on one side, retract the carotids on the other side, and the fascia in between. You know, this will be the inferior thyroid artery. So the triangle between the inferior thyroid artery, the carotid artery, and the trachea is the one which we will dissect in order to identify the recurrent laryngeal nerve in the triangle. Okay. So you take out all that small soft tissue which is have this nuisance bleeding, and then you keep dissecting over that area until you get the nerve. So once the nerve is identified, and then this is the nerve. Can you guys see this nerve? This white structure, that is the nerve. So once the nerve is identified, you go closer to the thyroid and release all the branches. Is the recurrent laryngeal nerve visible? So that linear white structure is the recurrent laryngeal nerve. So you dissect this all the way till its point of entry. Where does it enter? Can you see the blood vessels?
Into larynx.
Where? Which part of larynx? It enters.
Cricothyroid, sir.
Exactly. It goes in the cricothyroid interval, and then there it would supply all the extrinsic muscles of the larynx. So recurrent laryngeal nerve is one of the major nerve supplies to all the extrinsic muscles of the larynx. So if you get injury to the recurrent laryngeal nerve, what will happen to your voice?
Hoarseness.
Hoarseness.
Yeah, you're going to get hoarseness of voice, but if you look at the endoscope, you will see that the nerve paralysis is manifested by vocal cord paralysis. You know, the vocal cord will be in midline and not abducting at all. So in this instance, we are trying to dissect the nerve using a knife so that there is no cautery injury, no thermal injury because of the cautery. So you finish on one side and you repeat the same procedure on the other side. So yet again, you go for the superior pole of the thyroid gland first. Don't leave behind any thyroid tissue. Identify the pedicle. Skeletonize the artery and the vein. Ensure that you preserve the superior laryngeal nerve. And then you do the ligation. Okay. Once you know that there is no nerve that is involved in here, you can clamp and then you can ligate the superior pedicle. So there we go. So again, the same thing, extra facial dissection. Identify the superior parathyroid at this junction and then preserve it, from the facial aspect. Thereafter, you should go for the recurrent laryngeal nerve. Identify the inferior thyroid artery. Ensure that the vessels that is going to the superior, to the parathyroid glands are preserved, and then you divide all the terminal branches as it enters the trachea or the thyroid gland, and then you take out the thyroid gland. So while we are doing this, what is this compartment called? While we separate the tissue between the trachea and the carotid, and we are trying to identify the recurrent laryngeal. Can you see the recurrent laryngeal nerve and the inferior thyroid vessel? You guys can make out?
Yes, sir.
Yeah, so that's the vessel that is the terminal branch going to the thyroid. We divide that and then you demonstrate the recurrent laryngeal nerve here. Okay, so this whole length is the recurrent laryngeal nerve. And you dissect it right up to its entry point into the cricothyroid interval. And that way you are going to be preserving the nerve as well as all the branches that are going to the inferior thyroid branches that are going to the parathyroid. And you'll be only disturbing the terminal branches which are going to the thyroid gland. And there you'll see the entry point zone. And there you have to, when you go closer and closer, you start using the knife rather than the cautery to make sure we don't have any thermal damage. Then you divide all the ligamentous attachments and take out the specimen, which and once all the critical structures are preserved, then the thyroid can be separated off the trachea using either a cautery or a knife, whatever, and then you can skeletonize the entire trachea. Can you guys see the trachea here, the tracheal cartilage?
Yes, 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 yes.
And you must be ensuring that you leave behind no uh, smallest bit of thyroid tissue, because all this will be picked up by the radioactive iodine. So now you see there is a knife dissection of the thyroid gland of the trachea, and then here is the pyramidal lobe. You should make sure that you completely clean up the pyramidal lobe. Sometimes it may go very high up to the hyoid bone. So you must ensure that the entire pyramidal lobe is taken off. The nerve on the other side. And then you remove the specimen in toto. So in this level, if you were to see the lymph nodes around this region, what would you guys do? So what is the name of the lymph nodes along this recurrent laryngeal nerve?
Delphian, Delphian.
Delphian nerves are the three laryngeal nerves, three nodes here. It should be here. This is three tracheal nodes. The other one is paratracheal node along the recurrent laryngeal nerve. Okay, let me just finish this. We will go back to our slides. So far, any questions about the surgical part? Hmm?
Sir, can
No.
you repeat the boundaries for that current laryngeal nerve identification?
Recurrent laryngeal nerve. Okay, so it is a triangle. The triangle, the tip of the triangle, apex of the triangle is in the superior mediastinum. The medial and lateral sides of the triangle are formed by the trachea and the carotid artery. The base is formed by the inferior thyroid artery. Is that clear? So
Yes, sir. Thank
triangle
you, sir.
formed between the trachea on one side, carotid on the other side, and inferior thyroid artery on the third side is where you will look for the recurrent laryngeal nerve. And after you,
The apex,
I'm sorry?
apex was formed by, sir?
Apex is the junction of the carotid and the trachea. You know, if you go into the
Thank you, sir.
mediastinum, they will be very close to each other. Even above it is close to each other, but you retract the vessel and the trachea, and thereby you form the triangle. Okay, that is how. There is no pre-existing triangle. You create the triangle by retraction of the carotid and the trachea. Okay. So
Okay, sir.
that is what we do for safe preservation of the parathyroid gland and the recurrent laryngeal nerve. In fact, thyroid surgery is not about removal of the thyroid, but it is about preservation of the recurrent laryngeal nerve and the parathyroids on both sides. Okay, so that is the crux of the surgery. It's not about the removal, but it's about the preservation. So there will be instances when you will have to sacrifice the blood supply to the parathyroids, either because of its anatomy or because it is located inside the thyroid gland itself, so-called intrathyroidal parathyroid gland. So if that be the case, then you have to dissect them out, and then you have to do what is known as auto transplantation. How is it done? Auto transplantation?
Sir, in the forearm brachioradialis muscle.
Yeah.
Son
Once
of Ladomas.
you take it out, you mince it into very, very fine minced tissue, and then you can implant it any of the vascular muscles. I don't tend to put it in the forearm or anything. I tend to put it in a vascular sternocleidomastoid, and then you should mark that area with a non-absorbable suture, so that in future, if there was any need to go back in for a surgery in there, you would be able to localize that parathyroid once more. That is the idea. Okay.
In the presence of malignancy, do you dissect and put it in?
Which one?
In the presence of malignancy,
Yeah.
still tend to put some malignant thyroid also along with the parathyroid. Is that possible?
No. See, the parathyroids, and if it is directly infiltrated by your malignant thyroid tissue, then you cannot put it back. But if the parathyroid is completely away, and you know how parathyroids are? Parathyroids are nicely covered by a cuff of fatty tissue. So only if you dissect through the fatty tissue, you will see that brownish appearing parathyroid gland. You understand? So if that kind of plane is not there between the parathyroid and the thyroid gland, and the tumor is obviously infiltrating into that region, then you're not supposed to be reimplanting the parathyroids. That parathyroid you deliberately sacrifice. Sometimes it is very difficult when you have a lot of lymph nodes around this region. So you can have lots of lymph nodes in the central compartment, so-called central compartment, which is nothing but level 6 and level 7. Level 7 is the nodes in the mediastinum, and level 6 is all your paratracheal and the pretracheal and pre-laryngeal nodes. You can have a lot of lymph nodes in that region for two reasons. One is that due to cancer, which is obvious. You can also have a lot of lymph nodes in that region because of inflammation. And you'll see this time and time again in people who are having so-called Hashimoto's thyroiditis, especially in women. The thyroiditis incidence is higher And in those instances, you will be seeing lot of lymph nodes in that region. And when there is lot of lymph nodes, sometimes it may become very difficult for you to identify the parathyroid gland. So when there is difficulty such as that, then you have to take out the most suspicious looking parathyroid tissue, send a small bit to the frozen section, ask them to confirm whether it's a lymph node or a parathyroid. And if they confirm that as a parathyroid, you mince the rest of the tissue that you have preserved in saline, normal saline, and then reimplant it. The same.
Mani, do you have any slides going on at the moment?
Yeah, there is slide.
No, we can't see those.
Oh, okay, okay. I should need to share that. Okay. Okay. I will try to get that. Open the slide and then share it, isn't it? Share screen. Is it visible now?
Yeah.
Okay.
Yeah, fine. Fantastic.
So this is what we will do. Mince that parathyroid and then put it back for autoimplantation once the pathologist confirm that it is parathyroid. So the
So,
second substance.
have a thyroid adenoma.
Say that again.
What if you have a incidental parathyroid adenoma at the time of surgery?
See, the incidental parathyroid adenoma is something like finding a needle in a haystack, really. Most parathyroid adenomas are functional and they will manifest not as thyroid nodules, but they'll manifest with hypercalcemic symptoms. You will be having a lot of headache, you will have lots of stones forming in your kidney and all over the place. You'll have cramps, intestinal cramps. This sort of symptoms are the reason why your patient is going to approach you. And you may or may not feel a nodule in the neck. And you check their calcium, they're going to show calcium levels above 11 or 12. And then you suspect that it is possibly to do with thyroid, parathyroids. And the only distinction you want to make is it hyperplasia of the parathyroid or is it adenoma of the parathyroid? Very, very rarely you will get cancer of the parathyroid, which is the exception, 0.1 or 0.2%. But most often it will be adenoma. And the issue here is about localization. So you would then go into localize the parathyroid either by way of sestamide scan or by way of ultrasound if it was large enough. So incidental parathyroid adenoma is an exception. You would always see only normal parathyroid gland in thyroid surgery as such. And that is also picked up. See, sometimes, you know, you may be, if you want to stretch your imagination, it is not happening usually in the MTC, which is the part of the MTC means medullary thyroid cancer, which is part of your multiple endocrine neoplasia syndrome. So only in the type 1, you will get this parathyroid hyperplasia and all that. But medullary thyroid cancer distinctly is in the type 2, where your parathyroids are not so much involved. Okay, so even if you take that, maybe whether if it will happen in medullary thyroid, it isn't the case. So you will not have any kind of confusion between thyroid cancer versus parathyroid if you did a proper preoperative workup.
Okay.
All right. Okay, so most of the parathyroid glands, not most, all the parathyroid glands that you are seeing during a thyroid surgery are normal parathyroid glands. All right. Yeah. And it's a must and it's mandatory that you preserve all 4 of them as far as possible. If there is, for any reason, you need to sacrifice them, you need to document why you are sacrificing them. And the reason you will sacrifice is direct infiltration of the cancer into the parathyroid. All right. Yeah. Same is the case with your recurrent laryngeal nerve also. Your recurrent laryngeal nerve, you have to preserve at all costs. Suppose you want to sacrifice the recurrent laryngeal nerve, you should demonstrate that there is tumor infiltration in the nerve, and you must resect that segment of the nerve involved by the tumor with clearance, and then deal with the paralysis later. Okay. So the treatment for thyroid cancer doesn't stop with surgery. It has to continue with more medical treatment, and the medical treatment can be 2 parts. One is the thyroid suppression, That means you give them a higher dose of thyroxine to the point where you will have to suppress the TSH, the thyroid stimulating hormone. So, what is the normal acceptable thyroid stimulating hormone levels when you do a replacement dose? What is the normal level? Anybody?
3 to 5, sir.
Yeah, 3 to 5 international units per liter. That is what your normal level has to be. Now, if you want to suppress, what is the level we need to take it to?
20.
0.1, sir.
We need to take it as close to 0 as possible.
0.
Maybe you can accept till 0.1, maximum 0.2. Okay.
Two.
So you cannot have TSH level going above 0.1 or 0.2. It should be much less than that. So therefore, you would possibly end up giving about 1.5 micrograms of thyroxine per kilogram body weight. Is that clear? So you would be giving suppressive dose and you would check your TSH to show that it is closer to 0, maximum up to 0.1, and then you know that you're doing good with your suppression. The other part of the medical treatment for the thyroid cancer would be radioactive iodine treatment. Is that clear?
Yes.
So the radioactive iodine, when I say radioactive iodine, what is that we are talking about?
It will be a diagnostic scan now, sir.
Yeah, so you can have a diagnostic scan and you can have a therapeutic radioactive iodine. So for a diagnostic scan, you can either use iodine 123. Have you heard of it, iodine 123?
Yeah.
Yes.
Yes, sir.
Anybody has seen being used?
No, sir.
No.
No, sir.
Why? Why not seeing it being used?
Half-life is
Half-life is less.
Very short. Yeah, that means you must be able to manufacture the iodine right inside your hospital. So you must have a cyclotron to manufacture the iodine 123 so that you can give it to your patients immediately. But iodine 131 is what is commonly used. And what is the half-life of iodine 131?
8 days.
8 days.
8 to 14 days.
Yeah. So you have a longer half-life. So you can manufacture that in your bark, in Bombay, and you can put it in shielded capsule and you can transport it to all over the country. And you can get that in Chennai and you can use it for a day or two. Okay, so that is how iodine 131 is used. So the iodine 131, you can use it here for both scan purposes as well as treatment purposes. So what is the difference when we use it for scan and what is the difference when you use it for treatment?
Dose is less.
Dose is less.
Is less. Yeah.
What is the dose for the scan?
1 to 3 microcurie.
Yeah, it is based on microcuries. Okay. Whereas for treatment, you give in terms of millicuries, which is like almost 1,000 times more high dose, isn't it?
Yeah.
So the initial thing is you give a microcurie dose of 50 to 60 microcurie dose of iodine 131 and do a whole body scan after the thyroidectomy is completed. How long after the thyroidectomy is completed?
4 weeks. After 4 weeks.
4 weeks. Why 4 weeks?
Because the TSH level is
to raise.
Because the TSH level is
Has to be more.
Has to be raised.
Why does it take TSH? Why does it take 4 weeks for the TSH level to go up?
Half-life of T4 is also
Half-life of
T4.
Exactly. You're brilliant. So the half-life of T4 is 7 days.
7 days.
So you will have to wait for 4 half-lives before you can expect the thyroxine, the TSH to be elevated to its maximum. Okay, so till the entire T4 in the body is consumed, you will not see the rise of TSH.
Yes.
During that time, what are the other precautions you will take? While you wait for the T4 to be completely consumed, what are other precautions?
Avoid any kind of iodine intake.
Absolutely. So you have to go on a diet. Diet is free of iodine. So
Iodine.
whether it comes from medicines, whether it comes from cosmetics, whether it comes from diet like fish or others iodine-containing food, you have to avoid all of them. So you should be iodine starved completely,
Hmm.
and you must be having a high TSH level. And these are the two important prerequisites by which your radioactive iodine will act.
Yeah.
Now, suppose you have done the entire total thyroidectomy,
Yeah.
where would this radioactive iodine go and act? You have removed all the disease. There is nothing left behind. So
Yes.
where do you think is the radioactive iodine going?
If any residual tissue is present.
In papillary carcinoma.
So, however meticulous you can do a surgery,
R0 resection is
still,
not
still there will be some microscopic residue left behind. Okay.
Yeah. Yeah.
So those are the microscopic residue that the iodine will seek. The iodine, radioactive iodine will seek.
Hmm.
Now, when the radioactive iodine seeks, is it normal thyroid cell or is it cancerous cells that it will seek?
Sorry, sir.
Both, sir.
We removed the total thyroidectomy because there was a papillary cancer in the thyroid. Okay.
Yeah. Yeah.
Now there is only microscopic cells left behind.
Yeah.
The microscopic cells may be the cancerous
Cancer.
cells or it can be normal thyroid cells.
Yeah.
When you do give radioactive iodine, does it go to the thyroid, normal thyroid cell, or does it go to the cancerous cells?
Cancerous cells.
Cancerous cell.
In fact, it is both.
Both.
Understand?
Either way, both.
It goes to both.
Okay.
It actually goes more into the normal cells, and depending upon the iodine, what is known as the sodium iodide symport mechanism. So the sodium iodide symport mechanism is, if it is intact in the cancer cell, then the iodine will enter that cell. You remember we earlier saw certain molecular changes related to papillary cancer, and you will wonder if there was certain genetic changes that will affect the iodine intake, and therefore it will make it less effective. Understand? So most of the time the normal cells will pick up the radiation, and then when the gamma when the beta rays emit from that, that will also kill the adjoining cancer cells.
Mm-hmm.
It is called the bystander effect. Okay.
Okay.
So if your cancer cell is able to take the iodine directly, it will get killed by its direct action.
Mm-hmm.
The cancer cells are unable to pick up, then it will be at least killed by the bystander effect that's from the normal cell. So that's how it works. Is that clear?
Yeah.
So why should we do this treatment? Why should we take so much pains to wait for 4 weeks? We should keep them on diet. We can make them so hypothyroid that these people become really fat and lethargic and constipated. So much of difficulty. So why should we go through all this difficulty?
To prevent recurrence.
Yeah. So one of the things is that it does help in preventing recurrence. So you have to use it appropriately. It prevents recurrence when it is stage 3 or stage 4, or in other words, T3 or T4 rather.
Yeah.
So T3 or T4 is when it will be most effective. When it is T1 or T2, we are not sure whether it is really helping or not. So in the T1, T2, only if there is very poor prognostic features, then the radioactive iodine will be effective.
Mm-hmm.
So even otherwise also, we continue to use radioactive iodine. Why? In spite of even in T1 and T2, we use radioactive iodine. Why?
Metastasis. Occult carcinoma.
To prevent occult
Micrometastasis.
Micrometastasis. Okay. I mean, when you have T1 tumor, you rarely ever get metastasis. Okay. In a differentiated thyroid cancer, about less than 2 centimeter, you will rarely ever get metastasis.
Mm-hmm.
So that is not the right answer. What is the more correct answer?
follow up.
For the
There will
follow-up,
be always some thyroid tissue left in the rectal-laryngeal nerves.
And rectal angina, not supposed to leave behind the thyroid tissue. You saw that rectal angina we were dissecting, no? You skeletonize it completely. You're not supposed to leave behind thyroid tissue around the recurrent laryngeal nerve. That is a very poor surgery if you left behind. So it's a wrong surgery. You should clean up the tissue, clean up the nerve completely.
Aberrant thyroid.
Aberrant thyroid, you're supposed to
follow up.
Huh? What is special?
Thyroglobulin follow up.
Thyroglobulin and antithyroglobulin and
Exactly. So thyroglobulin, where is it secreted? Thyroglobulin.
Liver.
Follicular cell.
Follicular cells.
Yeah. Thyroglobulin is manufactured by the follicular thyroid cell. Whether it is cancerous or it is normal thyroid cell, it will manufacture thyroglobulin. So you're using radioactive iodine to ablate all these cells. So if you ablate all these cells, and then after a period of time, the thyroglobulin becomes normal. And then over the follow-up, if you start seeing them rising in trend, then you know there is a relapse of the cancer. That is why you need to completely ablate all existing thyroid cells by way of radioactive iodine. So the radioactive iodine is used, one, to reduce recurrence, treat the metastatic disease if there was metastatic disease, but more importantly, to have a follow-up, accurate follow-up of these cases. That's why you use radioactive iodine. Okay. So in this slide, you're actually seeing a case where we deliberately resected the recurrent laryngeal nerve. And then, as a matter of fact, you do what is known as the ansa cervicalis anastomosis. So this can be done. So you can take the ansa. Which ansa are we talking about? The nerve.
Hypoglossal.
Yeah, branch from the hypoglossal nerve and one
Descending
from the
hypoglossal.
vagus nerve will join together to form the ansa over the interjugular vein. So you take that ansa and then you anastomose to the distal end of the resected recurrent laryngeal nerve as it enters the larynx. Okay. So that is one method of managing resection of the recurrent laryngeal nerve. So once we are done with the surgical treatment as well as the medical treatment, then our job is to look for recurrence of the disease and follow up. Okay. So the recurrence of disease can happen. Where will you look for recurrence?
Bone, lung.
Thyroid bed.
Lymph nodes.
Important is thyroid bed, local recurrence. That is, you have to palpate the trachea. Now that you remove the thyroid gland, the trachea is almost subcutaneous, barring the strap muscle. So you must be able to feel that area better. But you know there is a little difficulty there because of fibrosis, post-operative fibrosis. So you must do a diligent clinical examination to look for local recurrence in the thyroid bed. So that is one area you look for. What are the other areas you look for?
Lymph nodes.
Lymph node.
Exactly. So you should look for lymph nodes in the central compartment neck as well as the lateral compartment of the neck.
Okay.
Now you must remember when we did the surgery and we picked up certain central compartment lymph nodes, and if they turned out to be positive, it is only a question of time in follow-up before the lateral group of nodes show up. Okay, it may show up in 2 years' time, 5 years' time, in 10 years' time, but the lateral compartment nodes will at some point in time appear if you have found the central compartment nodes involved. Okay. So you must have a very, very meticulous checkup for the lateral compartment nodes, which is usually by clinical examination or by
ultrasound.
ultrasound or by radioactive iodine scan, which is done once in 6 months. Okay, and thyroglobulin. So these are the ways that you're going to be seeing. So that is what we are showing in the screen. How we have now able to detect various types of recurrences. And the final thing is recently about adding PET scan. And why is PET scan important when iodine is so very sensitive and specific? Anybody?
Distant metastasis.
Bone mix.
Distant
Bone mix.
metastasis, iodine also will pick up, no?
The thyroglobulin would be elevated, but
Yeah.
But radioactive iodine is
thyroglobulin
negative.
will be
Any
negative.
Equivocal condition.
So what is that?
thyroglobulin elevated,
Yeah.
Tennis.
You see
Can it-
thyroglobulin elevated,
Thyroid elevation.
but
negative
iodine
iodine
is
scan.
not entering. So what does it mean?
Dedifferentiated
It's
tumors.
not iodine a bit.
Yeah, so it is not iodine avid. So if it is not iodine avid, we must check whether if we prepared the patient properly, go back and check whether they did the dieting properly, whether they have not taken any iodine inadvertently, whether they continue with the thyroxine or not, whether the TSH level has come up to that range or not. And so you will check that. Is there a method wherein you can do this without waiting for 4 weeks?
Thyrogen treatment, recombinant TSH.
Yeah, so you can use instead of endogenous thyroid stimulating hormone, you can do recombinant thyroid stimulating hormone, which is like an injection given on 2 consecutive days intramuscularly, about 3 days before you do the radioactive iodine. Okay, so suppose you have to give the injection today, first injection, tomorrow the second injection, you can give them the iodine on Monday. Okay, that is how you deal with the recombinant TSH. So for this instance, you need not wait for the 4 weeks. Anyway, the reason why we are doing PET scan is there are certain, like we earlier said, there can be some molecular changes, some mutations in the genes, which will prevent the iodine from entering the thyroid cancer cell, regardless of following all the procedures and protocol meticulously. So if that be the case, you have an iodine resistant or iodine refractory disease, and the iodine refractory disease is easily picked up by the PET scan. So when it becomes iodine refractory, it is also becomes very sensitive for FDG, glucose. Okay,
Yeah.
so
Okay.
that is why you use this as a complementary investigation for iodine. All right.
Yeah.
And then, of course, when you do see local recurrence whatsoever, where are we? What is this? Okay, so the sensitivity of detection of thyroglobulin doesn't matter. All right, one of the things you guys should understand is the thyroglobulin levels must be measured in a proper method in a good laboratory, because it can give rise to either false negative or false positive elevation. Okay, so you must be very, very sure that you're dealing with a good lab and a proper method. And depending upon the method, you will see there will be a lot of changes. So you can do it by either radioactive immunoassay or by way of a serology assay. Okay, and the thyroglobulin, the magnitude of its rise and the doubling time, we call the doubling time. That is how often the values double its content. Okay, so if the doubling time was high, you're looking at a distant metastasis. If the doubling time of thyroglobulin is very gradual, then you're looking at local recurrence. So here you can see when it is in the bones, it is really, really high. In the lungs, it is the next highest. Whereas in lymph nodes of the mediastinum and the cervical lymph node, the thyroglobulin level will not be rising so high. Okay, so it will give you a sense of uh, two ways. It can give you whether it is local or distant, and it can also give you what is the magnitude of the disease, if disease burden, the so-called cancer burden. Okay, so if you had person who was disease free for at least 6 months to 1 year, and then you're having the thyroglobulin elevation, you look for whether it is a local recurrence or whether it is a distant recurrence. And if it is local recurrence, you have two alternatives. Either you can go back and do a surgery, or you can treat with a radioactive iodine. So you must talk to your nuclear physician and see whether if it is possible to completely eliminate the disease by way of radioactive iodine. Otherwise, you should seek the surgeon who would be comfortable to reoperate into the thyroid bed. To reoperate into the thyroid bed requires extraordinary skills because there will be a lot of fibrosis. All your recurrent laryngeal nerve and the parathyroid glands are going to be at higher risk. So therefore, you require a high level of skill in going back to reoperate inside the neck. But it can be done. So the next thing that we need to worry about is distant metastasis. So distant metastasis, the most common place that the thyroid cancer, the papillary cancer will spread will be to the lungs. And here you are seeing actually in the first slide where your chest X-ray will be completely normal. Okay, so in the follow-up, don't think that if you had a normal chest X-ray, they do not have metastasis. The same person, if you did a radioactive iodine, you will see that there will be disease all over the place in the lungs. Okay, so this is uh, because the metastases are like your carcinomatosis lymphangiomatosa. You know, it is all over the place, but very, very, very minuscule. And so you will be picking them up with radioactive iodine, but you will in the X-ray chest it will be near normal, but not as if all the lung metastasis will pick up the radioactive iodine. Only 75% of the lung metastasis will pick up radioactive iodine. And in that, it should be very, very small in size. Large, huge cannonball like metastasis and all will not pick up radioactive iodine that well. It should be this kind of situation where the X-ray chest is seemingly normal, but there is a lot of miliary deposits all over the lung. You can have metastasis little larger like this, visible on the chest X-ray, but then here you see the radioactive iodine is not picking up, but the FDG scan is showing a lot of metastasis. So here we are talking about iodine refractory lung metastasis, and it goes to show that it is a poor prognostic tall cell variant of papillary thyroid cancer that this patient had. Don't forget that these patients can present even at the outset with a brain metastasis. We have seen time and again school teachers who will fall faint in the middle of the class and they'll be brought to the emergency, and we'll see this kind of lesion, and then the neurosurgeon will go and resect this tumor only to find out that it is a metastasis from the thyroid gland, and the thyroid gland will have a very, very small or an occult primary tumor. So that is also possible. So the metastasis can come in all kinds of emergency situation. The other emergency is here where you can have spinal metastasis. It will deposit in the vertebral column, and the disease will come outside the bone into the soft tissue and compress your spinal cord. When it compresses the spinal cord, this person will come with paraplegia. This is a emergency. It's a surgical emergency. So when you see this kind of a situation, you must act immediately because the nerve recovery is dependent upon how quickly you react to the emergency. So if you quickly go and decompress the cancer, then they have a good chance of the recovery of the paraplegia. And you see in bones as well as in multiple other situations, you can have deposits of the papillary cancer. So the treatment of the metastasis would again we come back to dealing with by way of surgery in the bone metastasis or in the brain mets. For the lung, usually it is only radioactive iodine. And you have to combine the radioactive iodine with, at times, external beam radiotherapy also. And the thyroxine suppression will continue regardless. All right. So to summarize the thyroid cancer treatment, we are talking especially today only about papillary thyroid cancer. You'll have to stratify the risk which we are dealing with, and we must choose the right form of treatment and follow up very meticulously in order to be successful. But what is the 10-year survival of papillary thyroid cancers?
95%.
Yes, it is very, very high. So,
90%.
yeah, if you looked at it overall, but if you looked at it from a stage point of view, the locally advanced cancer or the metastatic cancer will not have that much of a high survival. We are talking about non-metastatic, good prognostic variety in which the 10-year survival will be 90% and above. So nowadays, because we know so much about the genetic composition of this tumor as well as the molecular details, more number of drugs can be used in the metastatic thyroid cancer setting. And so these are some of the examples where you can use what is known as VEGF, the vascular endothelial factor, growth factor receptor blocker like sorafenib, or you can use tyrosine kinase inhibitors as well, and they are all used for treatment of thyroid cancers. I think we stop here and until you have any questions.
Hello, sir. I have a question.
Yes, please.
Hello, sir.
Yeah.
Sir, is there any
Sir, if you
particular...
have to,
Go ahead.
Hello.
Yeah. You
Is
go
there
now.
any particular guideline to decide whether when to go for a prophylactic central neck node dissection in PTC?
Okay, so the reason you want to do prophylactic neck node dissection is one, it should be T3 or T4, all right? Or you during the surgery found out that the central compartment nodes were involved and multiple number of them were involved. In that case, you go ahead and do a prophylactic neck dissection in those cases. So you will have a poor histological variant. You may have a central compartment involvement. You may have T3, T4 lesion. You may have extrathyroidal disease. All these will be criteria to look for a prophylactic neck dissection. But in the differentiated thyroid cancer setting, it is no different to do a therapeutic neck dissection versus the prophylactic neck dissection. Both are equal. There is no difference in survival. The issue here is also that you don't have to worry because the neck nodes are easily detectable by your ultrasound. And what are the ultrasound criteria to tell whether if a lymph node in the neck is metastatic or not?
Hypoechoic.
Round. It will be round.
Yeah, so it is more rounder than oblique.
Loss of fatty hilum.
Loss of fatty hilum. Okay.
Sir, central neck nodes are not
Microcalcification.
detected in your ultrasound, I think.
I'm sorry.
The central neck nodes are not easily detectable in.
Central nodes you do by surgery. Central compartment you dissect in the surgery prophylactically and do a histopathological examination. But we are talking about lateral neck nodes. In the lateral neck nodes, the size means the roundness criteria. Then you can look at the vascularity of the node, the whether it is cystic. Is cystic node safe or unsafe?
Cystic is safe.
Cystic node means metastasis. So if you have a cystic node in the presence of papillary thyroid cancer, you should consider that as a metastatic node. It is not safe. Okay.
Hello, sir.
Okay.
Yeah.
Sir, is there any role in frozen section in while doing thyroidectomy, sir, for lymph node metastasis detection?
All right. So frozen section for the lymph nodes, yes, because the two reasons why you'll use frozen section in the lymph nodes will be one, there are too many lymph nodes. You don't know whether if they are metastatic or whether if they are inflammatory. So you want to check that. Number two is sometimes it will camouflage whether it's a parathyroid or a lymph node. So we need to check whether we are dealing with a lymph nodal tissue or a parathyroid. For that reason, you would get a frozen section for the lymph nodes. Insofar as thyroid is concerned, you will not use a frozen section if they suspect it is a follicular adenoma. Okay, you will not be able to make out the difference between follicular adenoma and follicular carcinoma in a frozen section at all. Why?
Capsular and vascular invasion.
Capsular invasion.
The capsular invasion and vascular invasion, you must study the entire tumor extensively. That means they may take hundreds of sections to see whether there is any invasion. So if you cannot see with one section during the frozen section period and tell whether there is invasion or not. You understand? So because it involves the study of the entire capsule, you cannot make it out during the frozen section. They will wait for the permanent section before they can call it whether follicular carcinoma or a follicular adenoma.
So sometimes the follicular variant of papillary, they report it as follicular neoplasm. So sometimes
if they say it is a cancer, you're happy, okay? Whether it is follicular carcinoma or it's a follicular variant of papillary thyroid carcinoma, your treatment is going to be the same. You'll do the same surgery, you'll do the same medical treatment. But if they did not say it is a follicular carcinoma, but they said it is only a follicular adenoma, then you cannot depend on the frozen section. Okay. Now, sometimes you have what is known as a borderline situation on cytology. Okay, so you had a 2 centimeter nodule in the thyroid. You did an ultrasound. You have a thyroid score 3. Okay, either here or there. And then you did a cytology. They also give a Bethesda grade 3. You understand? So this is an indeterminate nodule that you are dealing with. And especially if it is in the extreme of age group where you think you have to rule out a malignancy, then you may have to go and do a thyroidectomy and then send it for frozen section to know whether if that 2 centimeter nodule is cancer or not. Now, if it is related to a papillary carcinoma or a follicular variant of papillary carcinoma, they will be able to guide you intraoperatively by the frozen section report. But if it turns out to be follicular adenoma, they cannot help you. So you will only look at the positive report, and if it is negative, you will have to wait for the permanent section before you can take any further action on this. Is that clear?
Yes, sir.
Yeah.
Sir, when we know that we have to give the radioactive iodine in future after OT for diagnostic scan, how long we should not give the thyroxine suppressive dose, sir?
See, the first 4 weeks, you don't give any thyroxine at all.
Okay,
so you
sir.
want to make them hypothyroid and make their TSH go above 100. That is the aim. Okay, at least above 50 or 70 it should go. So you don't give thyroxine at all for 4 weeks. But as soon as the treatment is completed, let me say they gave, because of thyroid scan, they found there was a lot of remnant thyroid tissue left behind in the thyroid bed, or they suspect some metastatic disease elsewhere, then they'll give a higher dose. If there is none of this is there, then they can give a lower dose. What is a low dose and what is a high dose iodine treatment?
One is low dose, one is high dose.
The low dose is about 30 millicuries.
30 millicuries.
Okay, that is the lowest you can go. Between 30 and 60, it is less harmful. Okay, what are the side effects of radioactive iodine?
Mucositis.
Mucositis? No, you don't get mucositis like external beam radiation.
Teratogenic.
Teratogenic. You don't do it on pregnant people at all. You don't even do an X-ray. How will you give radioactive iodine in?
Sialadenitis.
Yeah, so you can have lot of salivary gland swelling and inflammation. Okay, because radioactive iodine tend to get aggregated in the salivary tissue also, besides thyroid gland. And you can get, the dreaded all this is temporary. Your salivary gland and all this is temporary. The dreaded complication is a second malignancy in future. So as far as possible, you want to try and reduce the risk of a second malignancy. So that is why you lower the dose, and that is why you avoid the dose in certain group of people. Okay, you avoid the dose when you deal with a classical papillary cancer, which is less than 1 centimeter, completely intrathyroidal, and there is no other disease elsewhere, and your thyroglobulin is normal. Then you can safely avoid any form of iodine treatment at all. Okay. So only if it is more than 1 centimeter, there is extrathyroidal disease, there is a poor prognostic variant, and there is some chance of residual disease being left behind. Your thyroglobulin level is high after the 4-week period. Then you have to necessarily give radioactive iodine because it reduces the recurrence rate.
Mani, I'm afraid we have to complete that because another 5 minutes we start the next lecture. It's been a wonderful lecture with Very good attendance. I think we need to follow up with the part 2 of thyroid cancer as and when you're
done. Definitely. Thank
Thank
you
you so much. Thanks for your
time.
time.
Thank you, sir. It was very informative.
Thank you, boys. Bye.
Thank you, sir.
Thank you so much.